Yes, sir. Hello.
Hello.
Yes, sir. We are live now. Over to you.
Over to Mr. Manoj from Intas.
Yes.
I think due to some reason, sir has logged out. I don't know. Sir, Gopal sir, if you can.
A very warm welcome to all the experts and delegates who are joining us for the Follicular Lymphoma CME Advances in Management. This is a daily Sunday feast which is being organized by Teachers of Teachers, Professor Dr. M.P. Agarwal. I would like to have a very warm welcome to our international faculty, Dr. Niranjan Rathore, who joins us from New Zealand, Dr. Riaz Ahmed from prestigious Rajiv Gandhi Cancer Institute, Dr. Hausa Bagal from Tata Memorial, and of course, Teachers of Teachers, Professor Dr. M.P. Agarwal. Without much ado, over to you, sir.
Thank you. Good morning to one and all. This is Dr. M.B. Agarwal, President, Mumbai Hematology Group, welcoming you to the next edition of our pre-lunch live webinars. Today's episode is on follicular lymphoma advances in management. This is brought to you by Mumbai Hematology Group, supported by Intas and managed by Mice Ideas. I'm grateful to Mr. Manoj Kumar from Intas, the team from Mice Ideas headed by Mr. Rajesh Sharma, Yash Agarwal, Kalpesh and others, Executive Committee of MHG for giving this opportunity to me to conduct these webinars, faculty of today's live webinar, which have 3 speakers from India and 1 from New Zealand, and all of you participants for sparing your Sunday morning for this academic event. As usual, we will have questions at the end, and I request you to put in your questions in the box at the right top throughout this session, and it will be a pleasure for the faculty to answer those questions. We have the feedback form for you to give us the feedback, and also the attendees will get their certificate once they fill the feedback form. Teachers for today include Dr. Riaz Ahmed from Delhi, Dr. Bhausai Bagal from Mumbai, and Dr. Niranjan Rathore from New Zealand, and myself. I will just like to introduce you our next live webinar on next Sunday, which now falls in the month of August. And in that, you will be exposed to everything about lenalidomide, the versatile immunomodulator. So do contact Kalpesh at miceideas.in for registering for our webinars. So this email ID should be in your diary, kalpesh@miceideas.in. Well, thank you so much for giving this opportunity to introduce this webinar to you. And now it's my pleasure to introduce the first speaker, my friend, Dr. Riaz Ahmed. He's a DM in clinical hematology. He's consultant in hematology, hemato-oncology, and transplants in the Department of Hematology at Rajiv Gandhi Cancer Institute and Research Center, Rohini, New Delhi. So over to Rayaz.
Very good morning to everyone, and thank you, sir, for inviting me on this Mumbai Hematology Group platform to give lecture on this follicular lymphoma. My topic of today's webinar was treatment of limited stage follicular lymphoma, that was stage 1 and stage 2. So once a patient has been diagnosed follicular lymphoma, the treatment consideration, whether we should start treatment in early stage, whether we should wait, and which treatment should be given is a little controversial. Because of the paucity of the cases in this part of the world, and all the data what we have is mainly in the European and the American Western world, and they don't have the low-grade lymphoma. Basically, we need a long-term follow-up, and the rarity of the disease makes it difficult because over the period of time, changing times, the treatment modalities have changed. So let's see what are the treatment options available for a patient of follicular lymphoma if it's in early stage, that is stage 1 and stage 2. So treatment consideration of newly diagnosed follicular lymphoma, we should always before we start the treatment, we should have disease stage, tumor grade, tumor bulk, tumor burden, symptoms, patient age and fitness, patient goals and priorities. Basically, whether patient is young, old, having comorbidities, what are our expectations from the treatment, whether we have to aim for CR, we are prolonging the PFS, and the quality of life. Next slide, please. Now, this is the GELF criteria for advanced high tumor burden. When we have, these are the few points given by the GELF when we need to start the treatment, and they should have one or more than one of the following: any mass of more than 7 or 7 centimeter in diameter, involvement of 3 or more than 3 lymph nodes, each 3 centimeter in diameter, presence of B symptoms, splenomegaly, compression syndrome, ascites or pleural effusion, elevated LDH or beta-2 microglobulin, cytopenias, and leukemia. So these are the few points we should always keep in mind when we start the treatment for follicular lymphoma. Next slide, please. Now, stage 1 and stage 2 continuous or within a clinically acceptable radiation field, whether it is grade 1, grade 2, or grade 3A, the treatment consideration always has to be bulky versus non-bulky, presence or absence of B symptoms, patient goals, and feasibility of radiotherapy in relation to the location of the disease. Next slide. And as I told, it's very stage 1 and stage 2 follicular lymphoma accounts for up to 15 to 20% of the follicular lymphoma. Median survival ranges from 25 years from diagnosis. Radiation therapy is generally the treatment of choice for the limited stage follicular lymphoma. Next slide, please. So we will have some slides on radiation therapy. Next slide, please. Now, I've taken 2 articles. First one is the clinical from clinical investigation lymphoma, long-term outcome and mortality trends in early stage grade 1, grade 2 follicular lymphoma treated with radiation therapy. 106 patients were enrolled, all of stage 1 and stage 2. 76% received radiation therapy, 24% received radiation plus chemotherapy, and 15-year overall survival was 62%, and median survival time was 19 years. That has a quite long follow-up. The next was article is the original improved survival in patient with early stage low-grade follicular lymphoma treated with radiation. In this paper, they have taken stage 1, stage 2 patients, 6,568 patients, 34 patients were initially treated with radiation therapy, and disease-specific survival at 5 years was 90, and 10 years was 79, 15, 68, at 20 it was 63%. Of the patients who were not given treated, those who were only followed with wait and watch. And the most common cause of death was lymphoma in about 52% of the patients. So this is one of the longest, most number of the patient of low grade and the largest series of patient receiving radiation therapy. Next slide, please. Now, the radiation therapy, what was the dose, how to calculate, what was the dose, what dose has to be given, and there are two papers I have taken. One is the taken with the 40 to 45 gray versus 24 gray. Now, in this paper, reduced dose radiation therapy for local control in non-Hodgkin's lymphoma in a randomized phase 3 trial. Number of patients were 365 indolent lymphoma, predominantly it was follicular non-Hodgkin's lymphoma and marginal zone lymphoma. There was no difference in the overall response rate and PFS and OS. This same whether you give 40 to 45 gray versus 24 gray. The other praise whether 24 gray was too much or whether we can get away with the reduced dose of 4 gray. In the other paper, that is 4 gray versus 24 gray radiotherapy for patients. This is the 4 trial randomized phase 3 non-inferiority trial. And after a median follow-up of 26 months, 91 local progressions, 21 in the 24 gray group versus 70 in the 4 gray group has been recorded. So low dose may not be the ideal situation. 24 gray, hence in both the papers, 24 gray is the maximum dose which has been accepted in follicular lymphoma, stage 1, stage 2 disease. Next slide, please. Now, even if the radiation has been there and we are planning, in this paper in the Journal of Clinical Oncology, radiation therapy is not considered standard therapy in majority of the cases. Now, this 471 patients of stage 1 follicular lymphoma, of which 206 patients underwent regress staging, less than 1/3 patients were actually treated with radiation therapy. Whereas 28% with radial chemo, RT, and 27% observation in 17% systemic therapy, plus RT was given in 13%, Rituximab monotherapy in 12% and 3%. So not everybody is on the same page with the over advent of time that okay, radiation is alone, or whether we have to give radiation chemo or Rituximab monotherapy or wait and watch. So over a period of time, what it was like pre-Rituximab era, people were confirming with whether we to give radiation and chemo versus wait and watch. Post-Rituximab, it has been Rituximab monotherapy, Rituximab plus chemotherapy, observation or radiation. So radiation, over a period of time, the role of radiation therapy is coming down. Next. Now, these are compilation of different studies of patient receiving predominantly radiation therapy and at least one treatment arm. So, which we have seen the median age at radiation, age of presentation is in the 50s, and all these papers, number of patients we have seen from 80 for 50 patients to 124 to 200 patients they have taken into this cohort. Next slide, please. And same in the follow-up, what the same papers and the follow-up, and we can say 10-year overall survival ranging from 60 to 70 to 80% in this follow-up, and the 10-year treatment to progression, it was almost 50 to 59%, where overall survival ranged from %. Next. The next strategy is wait and watch. Next slide, please. Now, this paper in Journal of Clinical Oncology, stage 1 and stage 2 follicular non-Hodgkin's lymphoma, long-term follow-up to no initial therapy. At the median follow-up of 7.2 years, 27 patients had not been treated, and 63% of the patient. And if significant morbidity, we are considering that the patient can have significant morbidity from the radiation, and it's not the position of lymph node is such that if we giving a radiation therapy is going to cause more harm, we can have an option of wait and watch that was more reasonable. So in this says that if significant morbidity is possible from RT based on disease location, that's cervical Sicca syndrome, hypothyroidism, abdominal mucositis, or myeloablative suppression, or if the patient chooses not to receive radiation, wait and watch may be a reasonable alternative. Next slide, please. Now comes the combined treatment modality. Now this has been pre-Rituximab era and post-Rituximab era. Next slide, please. Now this trial, that is randomized trial of systemic therapy after involved field radiation therapy in patient with early stage follicular lymphoma, that is STROG 99.03 trial. Next slide, please. Now what next? I think so we moved one slide prior to this, one slide, yes. Now in this, what they have done is, this was started in 2000, and initially they randomized between chemotherapy versus radiation. That was, they have labeled that cohort is early IFRT versus early chemotherapy plus IFRT. Once in 2006, they started taking Rituximab chemotherapy, so they have made it late RCBP plus IFRT versus late IFRT. Now, when they evaluated the result, the progression-free survival by period and arm, we can see this, that late RCBP plus IFRT had the best progression-free survival, almost 90% over a period of 9 years. Next slide, please. Now, this is ME trial, that is treatment of limited stage follicular lymphoma with rituximab immunotherapy and involved field radiation therapy in a prospective multi-center phase 2 trial, that is ME trial. Next slide. Now, this is when rituximab monotherapy was being given. This is the treatment protocol of them, and followed by restaging of the involved sites and involved field radiation of 30 plus minus 10 grays, and along with rituximab, and the staging of this and 30 months follow-up. Next slide, please. And they are saying almost 75% of the patient has progression-free survival at the period of 108 months follow-up. So this combined modality, next slide please, has been better as compared to only radiation in terms of progression-free survival. Now this is a list of other in the trials which has been conducted over a period of time of combined modality radiation plus IFRT, rituximab plus IFRT or radioimmunotherapy, rituximab plus IFRT, R-CHOP. So this also has the same amount of progression-free survival. Next slide, please. And results which way they gave in whether it was single arm or whether it was double arm, you can see at the short follow-up of 2 to 5 years, 90% in the first trial that has IFRT, and rituximab 90% in 2 years, and you can say rituximab plus IFRT in 24 years at 6 years median follow-up. They all had some 80-90% follow-up. At progression-free survival was better in the combined modality arm. Next slide, please. Now, when we are giving radiation in localized stage follicular lymphoma, there is always a % of histological transformation. So once we give radiation therapy and we follow up over a period of time, what are the chances of recurrence in the radiation arm group? This was almost 7 to 10% in different studies, which has been elaborated in this slide. Next slide, please. Now, the ASMO guidelines in the stage 1, stage 2, low tumor burden, what they have given is radiation therapy 24 grays. In selected cases, you can consider watchful waiting or rituximab monotherapy. Next slide, please. Now, so the recommended strategies for early stage follicular lymphoma are involved site radiation therapy is the preferred treatment for limited stage disease. Strategy prolongs survival and has a curative potential. 10-year overall survival rate is almost 65 to 75%. Median overall survival is almost 15 to 20 years. 24 gray appears to be the optimal dose. Involved site radiotherapy should be used with caution with patient with disease near critical organ, where toxicity may outweigh benefit. Next. Observation or rituximab monotherapy may be considered in patients who do not wish to receive radiation, where it is contraindicated due to location of the disease. These strategies avoid adverse event of radiation to cervical or abdominal areas. For patient with bulky disease or disease with other adverse clinical or biological prognostic feature, systemic chemotherapy with or without radiation can be considered. Next slide, please. Now, the shortcoming of existing data is, as localized disease, as I have told earlier, the localized follicular lymphoma is a rare entity. There may be very limited number of large studies published in modern era, starting with introduction of rituximab, but also gradually decreasing fields and doses of radiation. So now we need to have long follow-up for taking the side effects and the comorbidities in picture. So this is a limited in recent era. And as the biological and technological and therapeutic improvements have taken place in last years, and we know more of a genetic involvement, we need more number of studies to see early stage follicular lymphoma, whether combined modality is better than wait and watch or radiation therapy. Thank you.
Thank you, Dr. Raj. We will now go to the second part of this webinar, in which, in fact, we have got two things. One is a MCQ-based discussion and then a lecture. So in the next 40 minutes, we are going to handle this. I request Kalpesh to put on the slides for the MCQ. Right. So subject for me is management of newly diagnosed systemic disease. So we are going a step ahead. Raya just told you about localized disease, stage 1 and 2, and I'm going to tell you about systemic disease, that is stage 3 and 4. And the next one. So for all the participants, we have now 5 MCQs. We will read out the question to you and the options, and then you will have 20 seconds because there is some delay in transmission to you. So you'll have 20 seconds for you to click and answer whatever question has been put as per whatever you feel is the best, because there may be no perfect answer for these 5 questions. So the first question is PET scan essential for all the patients of newly diagnosed follicular lymphoma? So should you always do a PET scan for all patients of newly diagnosed follicular lymphoma? Yes or no? Your time starts now. So Kalpesh will in few seconds show us your voting pattern. So we have almost equally divided house. A little more than half felt that it is required, and 45% felt that it is not essential for all the patients. So that's very interesting. So that will be our first point of discussion during my lecture. We can go to the next MCQ. So this MCQ number 2 is, which is the best chemotherapy backbone? You know that what Rayaz discussed about radiotherapy is not the standard of care for advanced disease or systemic disease. We always give chemotherapy. So which is the best chemotherapy backbone? And we've got 5 options here. Chlorambucil alone, CVP, that is cyclophosphamide, vincristine, prednisolone, CHOP, that is those 3 drugs with adriamycin, bendamustine alone, or FCM, that is fludarabine cyclophosphamide with mitoxantrone, oblique fludarabine with mitoxantrone. So you've got 5 options here. Which is the best of these chemotherapy backbone? Your time starts now. So in a couple of seconds, we will see your voting pattern now. So almost no one is for chlorambucil alone. There aren't many takers for CVP, 5%. Again, the house is equally divided between CHOP and bendamustine, and there aren't many for the FCM. So we'll have a good discussion on CHOP versus bendamustine. Okay, so we go to the third question. So as you know that it's not just chemotherapy, it is chemoimmunotherapy. And we use a CD20 antibody with all that backbone, that whatever you've discussed. You got two options in this antibody business, rituximab and obinutuzumab. So which one do you select in your practice? Your time starts now. So we'll see your selection. I'm sure this time it's not going to be 50-50. So we have 85% of you going for rituximab and 15% of you going for obinutuzumab, and we will discuss this issue as well. We go to the next MCQ. Many patients and many doctors won't like to give chemotherapy. So is chemotherapy free treatment an option for newly diagnosed systemic follicular lymphoma stage 3-4? Yes or no? Your time starts now. We will be soon seeing the results. So you have a little interesting division. 2/3 of you say that chemo-free treatment is an option, and 1/3 of you feel that chemo-free treatment is not an option. So we will discuss this as well. And the last question: should histological transformation be a major concern to you? Histological transformation, a follicular lymphoma, low-grade lymphoma going into a high-grade lymphoma, DLBCL. Is that a concern for you? Major concern for you? Yes, no? Your time starts now. That's the last MCQ. Right, so let's see how many of you are considering histological transformation as a major concern. So majority, 8 out of 10 feel that this is a major concern. So that finishes with the MCQ, and now I'm going to share my screen, and then we will have discussion on all of these. Am I sharing my screen?
Yes, sir.
Okay. So let's have now this talk, which is totally based on these 5 MCQs. Management of newly diagnosed systemic disease. Where are we? And where are we going? Lot of advances have taken place. Follicular lymphoma is the second most common non-Hodgkin lymphoma across the world. It represents 20% of all NHL cases, and in US, where we have genuine figures, the annual incidence is 5 per 100,000. It is genetically characterized by upregulation of BCL2, which develops due to 14-18 translocation. As Raya said, that only 20% of patients come in stage 1 and 2, so remaining 80% of patients present with advanced and incurable disease. However, in last 20 years, with the introduction of new treatment approaches, there has been remarkable improvement in the overall survival of follicular lymphoma grade 1, 2, and 3A. Presently, 90% of patients will be alive after 5 years, and the median overall survival is reaching 20 years. That means 50% of the patients are going beyond 20 years of their disease. This has made follicular lymphoma a chronic disease, and today many patients die with follicular lymphoma rather than due to follicular lymphoma, which is a big news. However, follicular lymphoma does remain a cause of death, and there's a cumulative incidence of about 10% dying due to follicular lymphoma by 10th year. And there is a little mortality which is treatment related, and fortunately that is small, 3%. We have improved our understanding about the biology of this disease. We have also learned a lot about the role of microenvironment in controlling this disease or making the disease aggressive. And this has been understood both at initial diagnosis and during the disease course. However, harnessing this understanding to prevent progression of disease by 24 months, popularly called POD 24. That means after you complete your treatment, will you be free of the disease for next 24 months, that is 2 years, or not? And that's very important, because if the disease comes back in the next 2 years, then you don't do so well. And also the transformation to high-grade lymphoma. Can we prevent that? These two have remained elusive goals. So if disease progresses in next 2 years, or it transforms into high-grade lymphoma, we still need to work a lot to help these patients. This is the general framework of upfront treatment for a newly diagnosed follicular lymphoma. You had a wonderful talk just now about the localized disease stage 1 and 2, and we discussed about wait and watch and radiotherapy. Once you've got to advance stage 3 and 4, then you can divide them into still probably an indolent disease, not progressing or gradually progressing, not having very high tumor burden, not damaging organs or bone marrow, and you can probably do exactly what Raya said, wait and watch, rituximab monotherapy. And with that, we finish this part of the talk. We now come to the rest of the talk, which is related to advanced follicular lymphoma, which is symptomatic. What do you do here? It is chemoimmunotherapy, either rituximab-based or Gazyva, that is obinutuzumab-based. Or what we discussed, chemo-free treatment. So let's take up your first quiz. The first quiz was, is PET essential for all patients of newly diagnosed follicular lymphoma? House was divided. 55% said yes, 45% said no. Let's see whether at the end of my next few slides, 100% will go for yes or 100% will go for no. Follicular lymphoma is FDG-avid disease in 98% of patients. So PET can be informative. PET is a must for better identification of truly localized disease. If Rayaz has a patient who looks like stage 1, stage 2, and I do a PET and show that there is a disease which is stage 3 and stage 4, then all the discussion that Rayaz did won't be applicable. Now, how do you do that? Not by your clinical methods, not by X-ray, not by sonography, not by blood test. You need a PET scan to know that yes, somebody with cervical node has got nodes in the tummy. PET is the most sensitive test to pick up extranodal disease. And that's important because extranodal disease, even in follicular lymphoma, does not speak so well about the prognosis. Also, PET is my guide to pick up histological transformation. If I've got a disease which looks like all low grade all over and I do a PET and my SUV value at one place is 17, I will be worried. I will do a second biopsy to see whether a high grade lymphoma has developed there and it's transformed. The treatment will be entirely different. And lastly, we will discuss, once you finish your 6 cycles of chemoimmunotherapy and end of treatment, EOT PET, if you do that, and if that EOT PET is positive, that means if there is a residual disease after 6 cycles of chemoimmunotherapy, that signifies a bad prognosis versus all other patients where EOT PET is normal. So this one gives you at least 4 points why you should do PET in a follicular lymphoma. Now, EOT PET. Predicting high risk of early progression is a challenge. My patient wants to know whether he's the one who after 20 years will be disease-free, or he's the one where the disease is going to be coming back within 2 years of stopping the treatment. Now, EOT PET tells me that if it is positive, then it's strongly possible that the disease will come back very soon. So recent data has demonstrated that EOT PET scan serves to identify patients who require very close surveillance for next 2 years. So if this PET was positive, I'll call patient probably every 2 months. If this PET is negative, I can call them every 3 months and then 4 months and every 6 months. These 2 years are the most crucial period for surveillance because patients who progress early, POD 24, progress of disease in 24 months, are at the greatest risk of inferior survival. And lastly, one which you and me are not doing regularly, but now our PET scan specialist has got the software to give this information to me and to you. Can you make out the tumor burden? Because tumor burden is a determinant of prognosis. You do that clinically, you do it with radiology, but can we do this with PET? Yes. PET can give you what is called TMTV, total metabolic tumor volume. It's a calculation. You have to just have the software. And if it is more than 510 centimeter cube, then that patient will not do so good. And this is independent of your FLIPI or FLIPI2 or even M7 FLIPI. In fact, you can combine TMTV with FLIPI2 and the two combination will give you the best prognostic information for early prognosis. Also, you can combine TMTV with EOT PET and the combination of these two will also give you a better prognostic value. There is one failure of PET. PET is not very sensitive to detect marrow involvement in follicular lymphoma. But then that information is superfluous. You know or you do not know whether marrow is involved or not involved. It's a bit academic because it does not change the prognosis and treatment. Lastly, coming beyond PET, besides clinical, genetic, and radiographic data, there are other tools to measure the tumor burden, which can tell you whether there will be inferior survival. We are not going to discuss this today, but these include mutational burden, measurable residual disease, circulating tumor cells, and cell-free DNA. All these four, at the moment, even in US and Europe, are research tools. So, is PET essential for all patients of newly diagnosed follicular lymphoma? If you are a French, you will say mais en abîme. What does mais en abîme mean? It means yes, and yes, and yes. When you have to forcefully say yes, the Frenchman uses that phrase. So, friends, probably those 45% who didn't want to do PET scan in a patient of follicular lymphoma will probably tilt and do PET scan from tomorrow for all their patients of newly diagnosed systemic disease or even in a localized disease to show that this is not systemic disease. We go to the question 2. And what did I ask you? I asked you what is the best chemotherapy backbone. And the house said CHOP or bendamustine. There was very little take for chlorambucil, CVP, and FCM. And the house was sort of equally divided between CHOP and bendamustine. So R-CHOP, R-bendamustine, or G-CHOP or G-bendamustine. Let's see. So we have got number of studies in the field of follicular lymphoma. The first 3 are relevant to my talk. The FOL05 is the oldest study. What did it do? It compared 3 protocols, CVP, with CHOP, with FM, and all, of course, with Rituximab. The STILL trial, what did they do? They compared what is the hottest for you today. Half of you voted for BR, half of you voted for R-CHOP. So we'll see the results of STILL trial. And the BRIGHT trial is almost similar. BR versus R-CHOP or R-CVP. So once again, these 2 trials will tell you whether to use CHOP or BR. And then the next question was obinutuzumab or rituximab as the immunotherapy, and we have the Gallium trial, which I'm going to cover. And I will leave to Dr. Bhausai to discuss the Prima trial, which tells you whether after all this you should observe or give maintenance rituximab. So my part is to cover the first 3 to answer the next quiz, and the Gallium to discuss the third quiz. So as chemotherapy backbone, most of the centers from US to Australia use either bendamustine or CHOP or CVP. It's very rare that somebody uses FCM. CHOP became available in 1976, 44 years ago. That time there was no rituximab. The efficacy of this increased when rituximab came 20 years ago, that was in 2000. And since then, R-CHOP is like a bread and butter for treating lymphoma. The FOL05 study was conducted by Italians. R-CHOP and RFM were shown to be superior to RCVP. 8-year progression-free survival with R-CHOP was 49%, RFM was 52%, and RCVP was 42%. This may not look very different, but I will soon tell you why RCVP went out of favor. First of all, RFM, which gave the best result. This went out of favor because it caused death. And these deaths were not related to lymphoma death. And you don't want a follicular lymphoma to die of your treatment. So RFM went out. RCVP, those patients who were on RCVP, they gave reasonable result, 42%, but at a very high risk of lymphoma progression at a very short time. In follicular lymphoma, time to the next treatment is considered as the best yardstick of your treatment. If your patient after any protocol requires treatment in 2, 3, 4, 5 years, then that's a bad protocol. And if he requires treatment after 5, 6, 7, 8 years, that's a good protocol. So RCVP, despite giving 42% success, the time to next treatment was short. So it is not comfortable. One is not comfortable. So based on this result, RFM is sparingly used and RCVP is reserved. Reserved, it's not out, it's reserved for, say, a 90-year-old man or a man who has got terrible physical fitness problem. So elderly people with not so fit, that population, you're scared of using drugs like bendamustine, scared of using adriamycin, you can still do RCVP. 40% of them will get into excellent response. And if at the age of 90, you've got few years of life left, what is wrong? Nothing wrong. So R-CHOP became the standard of care. I'm talking about FOL05 study. Okay, so there is a huge until. And what is that until? Until is this. And some of you probably are interested in history, and they will recognize this cartoon, they will recognize this wall, and they will recognize who the people on this side of the wall are. Now, what is this wall? This is Berlin Wall. And when the Berlin Wall fell, the East German united West German. And what was the benefit to a hemato-oncologist of the Berlin Wall falling? Huge benefit. A drug called bendamustine, which was being used in the East Germany without much scientific data because there wasn't much money to do research in the East Germany, now came to West Germany, and now came to rest of the Europe, and now came to US. And we have study based on this drug. And this drug became a game changer. This is bendamustine from our friend Intas, available as bench. And bendamustine takes over. For the first time, R-CHOP was really challenged in the STILL trial. STILL trial was comparing R-CHOP with BR in a prospective randomized fashion. More than 500 patients followed up for almost 45 months. BR showed significantly better median PFS than R-CHOP. 69 months versus 21 months. Hazard ratio 0.58, p-value, wow, 0.0001. So that's bendamustine for you, taking over R-CHOP. Bendamustine has arrived. We have now 10-year update on STILL study published in JCO last year. It confirmed a significant improvement regarding time to next treatment. Remember, that is the yardstick by which you measure how effective a treatment is. And these results were duplicated by BRIGHT study. They also compared BR on one side with R-CHOP and RCVP. At 5 years in BRIGHT study, PFS was 65.5% in BR, 55.8% in the other two drugs. Hazard ratio almost same, 0.6, with CI also good, and p-value of 0.0025. So got two studies favoring bendamustine over CHOP. And that's the graphic presentation. Blue is BR, and the orange is R-CHOP. R-CHOP is here, and BR is here. As the time passes, the difference becomes large. So there's a progression-free survival which was not reached in the BR arm. And that's BRIGHT study. Again, you can see the blue, which is BR, and the orange, that is R-CHOP or RCVP. As the time passes, differences increase. What's this lady doing here with all her hair? It's very important. The quality of life assessment. QOL. Both STILL and BRIGHT studies did not report QOL. But one thing that stood out is there is no hair loss with bendamustine. A man may feel that this is not important, but 50% of your patients will be women. And for her, it is important. No hair loss is a huge asset from the angle of adverse effects of BR versus R-CHOP. Also, it must be remembered that neither STILL nor BRIGHT study use rituximab maintenance after induction, something which I will discuss. So, bendamustine is preferred drug, BR is the preferred regimen. The dose of bendamustine is 90 mg per meter square. It is given for 2 consecutive days, day 1 and day 2, and the cycle is repeated every 28 days for 6 cycles. So that's undergraduate stuff. This dose needs to be reduced, or sometimes you omit the second dose depending upon the frailty of the person. So if you're an old man, frail person, comorbidities, you may either go to CVP or you could use bendamustine in reduced dose or bendamustine 1 dose per cycle. Overall, based on STILL and BRIGHT study showing better disease control with BR is now widely recommended transatlantic all over the world as the preferred first-line treatment option for follicular lymphoma. Over the years, there is significant data accumulated regarding a very new thing, which was not reported so much in STILL and BRIGHT study, and that is continuous infection toxicity of bendamustine. This side effect of bendamustine was not reported earlier, but now we know why it happens. there's a prolonged T cell suppression of CD4, causing infections even during second, third, fourth year after BR therapy. Based on this data, it is now strongly suggested to take infection preventive measures, including prophylactic antibiotics, antifungal, antiviral agents, and sometimes PJP prophylaxis, and also to keep a watch on CD4 count, which will guide you how long to continue these prophylactic measures, and also to vaccinate upfront all these patients against pneumococcal and H influenza. And from this token, after BR, Rituximab maintenance is a controversial issue. You should be extremely careful because you knock down CD4, and if you knock down immunoglobulin production, you've got B cell and T cell deficiency, exposing these BR patients significantly to infection risk. This compares the toxicity of BR versus R-CHOP versus RCVP, and just concentrate on the yellow zones. BR causes a lot of vomiting, which is in your hand. You can control it. It causes infections because of lymphopenia, and it can cause skin rashes. It doesn't cause hair loss. It doesn't cause much of neutropenia. It doesn't cause much of thrombocytopenia. R-CHOP does lot of neutropenia, lot of hair loss, and with vincristine, some amount of neuropathy. So the final verdict is BR is the preferred regime when it comes to systemic follicular lymphoma newly diagnosed. However, there is a caveat. The choice of BR versus CHOP versus CVP needs to be discussed with patients, and we need to individualize the treatment by explaining them the adverse effects of one versus second versus third. Degree of cytopenia, infection rate, hair loss, and the cardiac toxicity of atria. Not only that, if you feel that your patient of follicular lymphoma has a more aggressive disease, either based on histology, where the grade is 3B, or the clinical picture, dynamic or asynchronous progression, an area of lymph node has rapidly increased, SUV value is 13, 14, 15, the biopsy shows it is still follicular. In all such patient, or based on PET scan, you may prefer R-CHOP, because if the lymphoma is aggressive, you want to be aggressive. Similarly, elderly fit people, you may opt for RCVP. So my answer, the best backbone for chemotherapy is bendamustine. Our third question was, which CD20 antibody do you select? 15% of you said obinutuzumab, and we will see whether they are right or not. So rituximab is type 1 CD20 antibody. It has been around for exactly 2 decades plus. It was initially approved for relapse patient of follicular lymphoma, and then it made its way upfront. Obin, which will be the nickname for obinutuzumab for the rest of my lecture. Obin is type 2 CD20 antibody. It has a greater antibody-dependent cytotoxicity and causes direct apoptosis as against rituximab. In fact, the development of obinutuzumab was to produce a more potent antibody. So, in general, one would feel that when you are using obin, you are using a better treatment. First of all, addition of rituximab itself was a masterstroke. You see CVP versus RCVP, the difference in survival, difference in event-free probability. So today, hardly any follicular lymphoma will be treated without monoclonal antibody. Obinutuzumab, that's the molecular structure, that's how it's available. Gaziva, 1 gram in 40 ml, and that's the New England Journal article. Marcus was our guest speaker. He's the first author of this presentation, and I had pleasure of listening to him when he first time presented the data of obin versus rituximab as first-line treatment of follicular lymphoma. This is the Gallium trial. Now, what's the Gallium trial? Upfront follicular lymphoma, any kind of chemotherapy, CHOP, COP, Benda, whatever, 6 to 8 cycles depending upon which one you use, with rituximab versus Gaziva, that is obin. And then maintenance for 2 years, every 2 months, either with rituximab or with Gaziva. In the Gallium trial, the patients with untreated follicular lymphoma, Obin was combined with all these chemotherapies and compared in a randomized prospective fashion to rituximab plus chemotherapy, followed by maintenance with the individual CD20 antibody in both arms. 1,200 odd patients, huge study. Estimated 3-year rate of PFS was 80% for Obin, 73% for Ritu. Hazard ratio, very significant. P-value, highly significant. Now 5 years are over and the results have been published and the data has stood the test of time. In fact, there were a higher number of patients who achieved MRD negativity with Obin, which may explain why there was increase in PFS. The advantage of using Obin compared to rituximab was independent of which chemotherapy backbone you used. There was no effect, however, on the overall survival. In 2017, because of the Gallium trial, Obin was US FDA approved as first-line treatment of follicular lymphoma. So you've got the option of using R with blah, 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 or G with blah, blah, blah. And that's the difference, progression-free survival with Obin versus rituximab. And that shows you no difference in the overall survival. Problem comes here. So why 85% of you didn't vote for Obin is here. Adverse events, particularly infusion-related events, and more than that, the degree of neutropenia and the degree of infections were higher with Obin. And depending upon the chemotherapy backbone, if you used CHOP, then there were grade 3 to grade 5 adverse events related to cytopenia. And if you used bendamustine, it was worst. There were grade 3 to 5 infections even in non-neutropenic patients. And that's credit goes to bendamustine as a partner for Gazyva. So this could be the worst combination you can ever think of, Gazyva with Benda, because you knock down all your immune system. So you need to clearly educate your nursing staff about infusion reaction prior to the first dose of Obin. For fit and younger people, maybe Obin remains a reasonable therapeutic option, provided that patient is willing to take the risk of grade 3 or more serious adverse events for a little bit of PFS advantage, no overall survival advantage. So Obin is not so friendly. Most of the patients of follicular lymphoma are not young. You don't get 20, 30, 40, 50-year-old people. Therefore, I caution about universal consideration of Obin. Combining Obin with Benda is inviting trouble. Combining it with CHOP is inviting trouble with deeper neutropenia. CVP with Obin may be added as a safer option for elderly people who have got an aggressive disease. At the moment, NICE guidelines constrain use of Obin for follicular lymphoma. So if you are in UK and you use Obin, you will not be reimbursed. So my answer is 85% of you opted for rituximab. I 100% with rituximab. Question number 4. Is chemo-free treatment an option? And a large number of you said yes. So in upfront setting, whether chemotherapy free treatment is an option, we will review in next 10 minutes. So the drug is only one, lenalidomide. And the trial by which we go is the Relevance Trial, which is R-square. Revlimid, that is lenalidomide, with rituximab. That is the chemo-free option. Nothing else available to you, only this trial. Given the excellent outcome that can now be expected in patients with follicular lymphoma with chemoimmunotherapy, and 80% of them alive at 10 years after diagnosis, and 50% of them alive at the end of 20 years, the potential for short and long-term toxicity of chemo makes you excited about chemotherapy-free alternative. And that's why the Relevance Trial came up. In the Relevance Trial, patients with previously untreated follicular lymphoma meeting the JELF criteria received either R square or R chemo, and chemo could be anything. Total of again 1,000 patients, so large study, and both were treated for a total period of 120 weeks. And that is the first trouble. The treatment of the patient has to go on and on and on. In R square arm, patients were treated with LEN for 18 cycles. You can't forget this, 18 cycles. And R chemo was administered as usual for 6 cycles or 8 cycles, depending upon your protocol. Both received Rituximab Maintenance. So that's the study design. So here you got Rituximab with chemotherapy, 6 or 8 cycle, whatever may be, and then maintenance every 2 months for 2 years with Rituximab. And here you got R square, where you get LEN with Rituximab, and this goes on and on because LEN is continued beyond this 6 to 8 months for another year, and then only Rituximab to complete those 120 weeks. And in another sort of cartoon, you see R square going on, and then Rituximab maintenance, and this is 6 to 8 cycles of R chemo, and then Rituximab. There was no difference in overall response rate. There was no difference in 3-year PFS, and there was no difference in 3-year overall survival. So the results of chemo-free were equal to chemo-based arm. Although R2 failed to demonstrate a superiority over standard immunochemo. And because this was a superiority trial, hence could not get clearance from US FDA, and hence will not replace Rituximab chemotherapy as the first line of treatment, this trial showed that the two give equivalent results. Why is then a chemo-free arm not very popular? One, because of the long-term data that we have with CIT, chemo immunotherapy. 50% of the patients going for beyond 20 years. And when you see the Prima Study results, you realize how good the whole thing is. While R square, we have got 3-4 years data. And you have to go on giving LEN for long time with all its fatigue, GI disturbances, cytopenia, and other toxicities, and the cost involved. So this shows you how the ORR is equal. This is R square, R chemo. This shows you how the complete response rates is equal, R square with R chemo. This shows you how the PFS is equal. So overall rates of grade 3 to 5 adverse events were present in 65 to 68% of patients, but the toxicity profile was different. R chemo arm had grade 3-4 neutropenia, while R square arm had grade 3-4 cutaneous reactions. Similarly, infections of any grade or severe infections were more common with R chemo than R2. So R square is definitely more friendly. And this shows you the comparison of adverse events. R square, only the skin reactions were more. Rest everything was more with R chemo. So what are the pros and cons of R square? R square has outcomes which are similar to R chemo, albeit with a prolonged induction schedule. A shorter R square duration of therapy is under evaluation. That's very exciting, where R square is given only for 4.5 months. And present data published in Blood last year shows the median PFS of 5 years with this combination. And median time to next treatment not yet reached. So this trial could probably give a sort of fresh dose to this R square regime. In addition, combination of LEN with OB2 is under trial, under research published in Supplement Blood, because presented in ASH meeting last year. So LEN with OB2 has recently been reported to give very impressive outcome, but we only have a follow-up of 22 months. In this high tumor burden population, 2-year PFS was 96, wow. ORR was 98, again, wow. And 92% got CR at the first response assessment, which was day 1 of cycle 4. And follow-up and more mature data of LEN with OB2 is eagerly awaited. So in the real world, Importance of R square, a reasonable option if your patient or you hate chemotherapy. Duration of treatment at the moment is a nuisance. Land toxicity cannot be underestimated. And there is a prolonged use of rituximab. So you can't sort of, get rid of the so-called maintenance which you can do with the R-CHOP or BR. So my vote is that we are not yet ripe with chemo-free treatment, and I will not prefer this upfront. In refractory case, relapse patients, Niranjan is going to tell you how it is a good option. And my last question, and I have just 1 or 2 slides for this, is about transformation. Should histological transformation be the word here is major concern? Most of you voted for yes. The textbook says yes. So we say yes. And it's a subject to discuss. A lot of people will like to do research and publish and present, and therefore this is quite a popular subject to talk about in meetings. But look at this data published in Lancet 2 years ago. The risk of histological transformation before introduction of rituximab was very high, 28% at 10 years. So it was a concern. Every third or every fourth patient will develop DLBCL or something like that. These concerns have reduced in the current era. So what's the data? This is a massive study. Aristotle study, 8,000 patients with headquarters in Canada, reported only 6% of patients who received rituximab with whichever backbone of chemo developed histological transformation at 10 years. 28% if you didn't use rituximab. 5.9% if you use rituximab. Great, isn't it? And after Dr. Bhausap tells you about rituximab maintenance, this risk further decreased to less than 4% if you use rituximab maintenance, 3.6%. And the last, today the survival of histological transformation is not that bad. 32% of patients are alive after 10 years, even after histological transformation. And the reason is you are no more using R-CHOP upfront. You are using BR. So you got your R-CHOP left with you for treating this histological transformation and other protocols. And remember, CAR-T is US FDA approved for this group of DLBCL. So my answer is histological transformation is no more a major, it is a concern, it's not a major concern. So I conclude my talk by saying those 5 issues. PET is a must. Bendamustine is the backbone of chemo. Rituximab over Obin is the preferred monoclonal. Chemo-free regimes have to wait for upfront setting. And histological transformation is now, with rituximab-based therapy and maintenance, less of a nuisance. Thinking about the future, and just one slide, to identify biomarkers which can detect those 20% of patients who are high-risk follicular lymphoma who develop progression of disease in the first 24 months after your 6 cycles of BR. We need biomarkers for them so that we can treat them differently. Continue to develop targeted agents, which Niranjan is going to discuss, and innovate them upfront, either in place of chemoimmuno or with chemoimmuno. That's the second major goal. And to develop interventions which can prevent this little percentage of histological transformation that we are left with. We want to prevent that. So all those of you who are less than 40 years old, you've got 3 research agenda with you. Maybe you take it up. Follicular lymphoma advances are, there's only one word, wow. Well, thank you so much. With that, I stop sharing my screen and I request now our next speaker, Dr. Niranjan Rathod, to tell us about relapsed follicular lymphoma. Dr. Niranjan Rathod, MBBS, MD, DM, FRACP, FACP, is a consultant hematologist and bone marrow transplant physician in New Zealand in Department of Hematology, Venkato Hospital, Hamilton. Is honorary senior lecturer in Venkato Campus, University of Auckland. Over to Dr. Niranjan Rathod.
Yeah. Good afternoon to everybody. Can you hear me?
Yes, sir.
And can you see the slides?
Yes, very well, sir.
Okay. Sorry. Sometimes the technology. Okay. At the outset, I would like to thank Dr. Agarwal for giving me this opportunity. And it's always a difficult task to talk after your teacher and speaker like Dr. Agarwal. But I'll do my best to do the justification for the subject. Part of my talk is made easier by Dr. Agarwal's talk because he has already built a very good concept for you to think about what if these patients who are treated very well or those patients who are treated earlier and now relapsing, what would you do with those patients? So what are the important questions in patients of follicular lymphoma who was supposed to do well is coming back to you? So the first question, which Dr. Agarwal has already highlighted, is there a possibility of histologic transformation? And we definitely need a biopsy, and because the treatment would be definitely different. And there is now data developing, and as the mutations are coming up in all the hematological malignancy, EZH2, which is seen in 20% of the patient, suggests that it's a better prognostic marker, and now can be targeted with EZH2 inhibitors in these patients. So next important point, which if any patient of follicular lymphoma is relapsing, is this an early treatment failure? As defined earlier, this is POD24, that is if somebody is relapsing within 24 months and 20% of this patient do, they need to be treated differently and more aggressively, and that we will touch upon predominantly because rest of the group, when they're relapsing, most of them can even respond to the initial chemotherapy regimen, so it could be much easier to deal with them as compared to somebody relapsing early. Part of the explanation has already been given by Dr. Agarwal about rituximab versus obinutuzumab. Again, because I'm now addressing the question of somebody relapsing, and that's where we would get definitely benefited if we get access to more potent anti-CD20 antibody, that is the obinutuzumab, which is a type 2 antibody which has a more potent action, as Dr. Agarwal elucidated that it has more direct toxicity and antibody-dependent toxicity. Is there a role for maintenance? I think I will leave discussion to Professor Bagal to give you more detailed about the maintenance, but this is, as far as relapse is concerned, it's not very clear as the upfront maintenance. Which chemotherapy should be the backbone? And again, the options would include what was the first chemotherapy regimen that was used, and most of the time we would be able to just flip around and use the other. Say if it is CHOP, which is used with the monoclonal antibody, it could be then bendamustine, or now we can even use lenalidomide. Here there are no constraints. We have the approvals for lenalidomide that we will touch upon. And as a transplanter, I will definitely talk about which patients needs to be taken up for transplant. Is there any role for allogenic transplant in this patient? And of course, we will touch upon novel agents, which work and which we feel that should logically work are not working. So the first step is to rule out histologic transformation. When should we suspect? There is a rapid progression in lymphadenopathy, uncommon extranodal site infiltration, excluding marrow. Marrow is very commonly infiltrated in follicular lymphoma, development of B symptoms, elevated LDH and hypercalcemia. We should have definitely low threshold for biopsy because we want to confirm relapse or we want to rule out histologic transformation. And PET scan will be very, very helpful, particularly to identify a very hot node, which could be the node to biopsy for accurate diagnosis and for histologic transformation. And if patient has cytopenias, it's better that we do the bone marrow study. Diffuse large B-cell lymphoma is, of course, the most common histologic transformation type. And as I said earlier, it is treated differently with predominantly anthracycline-based chemotherapy along with immunotherapy and followed by transplant. Coming to early treatment failure, and that's the most important group when we are dealing with early in patients with relapse. So it's POD24. It's now very well coined term. Is associated. What we know that it is associated with poor outcome. And if you look at this study, it's quite large, which suggests that somebody relapsing within first 24 hours, the survival is definitely much lesser. This is the overall survival, and this is specific to those patients who are treated with R-CHOP chemotherapy. So 50% versus 90%, it's quite a bad outcome for any patient who is relapsing early. So what should be an ideal treatment approach when somebody is dealing with patient of relapsed follicular lymphoma? First, I would always prefer that we must do a biopsy at the suspicion. If there is a histologic transformation, of course, this is definitely treated differently. If the relapse is confirmed, like we do it on the first presentation, the next question which is asked, is there indication for starting the treatment? And again, if they have a B symptoms or some of these indication, then the time to treat is there. And then the next question comes, is this an early treatment failure? Early treatment failure is predominantly defined as those who are relapsing within 24 months of R-CHOP, BR, or RCVP. But if somebody is progressing even within 12 months of single agent rituximab, it will also be considered as a bad sign and should be treated a little more aggressively. If they don't have this kind of POD 24, then how do you decide? The options are chemoimmunotherapy, novel agent, single agent rituximab, or radioimmunotherapy. But of course, it will depend upon what was the previous chemotherapy regimen. As I said earlier, we might just flip around and use the same, either same regimen if it is too long time, or we just change it to vice versa, like CHOP versus bendamustine. How fit is patient, whether they can take intensive treatment or not? What is the center experience, whether you have experience with obinutuzumab or some of the Pi3k inhibitors, and the agents available, of course, remains a very important criteria. If they are an early treatment failure, of course, we must take into account right from beginning the need for transplant and then choose the treatment accordingly. And if they're candidate for transplant, we will definitely choose a very effective treatment which will put those patients into good clinical remission and will lead to lead to them to an autologous stem cell transplant. Those patients unfortunately cannot go into remission. Then there is a place for additional treatment, and that's where novel agent radioimmunotherapy, which is quite unusual in most part of the world, or allogeneic stem cell transplant, particularly if somebody is in partial remission. And somebody has put a question on CAR-T into the chat, and I would say CAR therapy right now for follicular lymphoma is investigational. If you see the ZUMA-1 trial, it had the follicular lymphoma represented. So they do respond, but there is a short response. So the duration at which the response is maintained is something which is a bit concerning. But as CAR-T is still a very early investigational agent, we still knowing more about it. And even in New Zealand, the CAR-T trial that we do have option open for follicular lymphoma to get enrolled if they are relapse refractory. So these are the wide options which are given for any patient who is relapsing for follicular lymphoma. And because if you see this, it's given as a preferred regimen, and it's up to you to choose. And then it becomes more tricky, like which one should you choose or what should be the sequence of treatment. But the treatment can be BR, R bendamustine, or obinutuzumab, O bendamustine, or R-CHOP or O-CHOP. Same way, CVP lenalidomide can be combined with either of the antibodies. They can be used alone, best in combination, but lenalidomide or monoclonal antibodies can be used alone. And now, as we most of you probably are aware, that recently US FDA has granted approval for EZH2 inhibitor in EZH2 positive patient, follicular lymphoma, who has relapsed after 2 prior therapies. Those patients, unfortunately, who are not very fit or have a very benign or they are relapsing after 24 months, can be even observed or can be treated again with single monoclonal antibody treatment like rituximab weekly for 4 weeks, or lesser degree of intensive chemotherapy like chlorambucil, cyclophosphamide can be added. And of course, the extended treatment is in the part of in the form of maintenance can be given. I again reserve those discussion to Professor Bagel to decide. And other treatment will include the transplant, and the transplant will mainly be in the form of autologous stem cell transplant and selectively allogeneic transplant, or referring to the CAR-T therapy. And I understand Dr. Anil Kamath is setting up the CAR-T program in India, so some of your patients could be part of it. So as far as if you go to what is the expert commentary on early relapse, if you go to How I Treat, which was recently published in Blood, so Dr. Casulo points out that these patients need to be dealt with aggressively. And in the discussion, the treatment option, which will include, if the patient is anthracycline exposed, then they're better off with bendamustine plus monoclonal antibody, and our preference was obinutuzumab. And if patient is anthracycline naive, of course, obinutuzumab R-CHOP or R-CHOP can be the treatment. And once they go into a remission, and again here the PET comes very important. Somebody is PET negative before transplant will definitely have better outcome, and they go for autologous stem cell transplant. If those patients are for some reason not candidate for transplant, then it's better that we start addressing these patients with targeted agents so that the toxicity is less, and that's where lenalidomide, either with rituximab or obinutuzumab or Pi3k inhibitors would come into handy. So these are some of the overall response that has been listed. Lenalidomide and rituximab, overall response of 48% with good PFS. And as Dr. Agarwal has already highlighted, the lenalidomide obinutuzumab can have very good overall response, and so is the Pi3k inhibitors. Coming to gadolin, which is a large phase 3 trial. So Dr. Agarwal talked about the gallium. So it's a gadolin which is mainly or similarly placed. The patients were initially screened, like 396 patients. They were either randomized to receive bendamustine alone, or where they were randomized to receive bendamustine plus obinutuzumab, and went on to receive obinutuzumab maintenance. And you can very clearly see that led to the combination of benda plus obinutuzumab led to improved progression-free survival in tune of 26 months versus 14 months. Overall survival, of course, failed to show that greater difference and was not clinically significant, or not statistically significant, I would say. As far as toxicity is concerned, definitely the biggest worry was that whether the cytopenias and the neutropenias will be higher. But when I looked into these details of trials, some of these are looking quite equivalent. Many times, as you know, the trial patients are treated quite differently than the day-to-day practice. And another suggestion which possibly comes from the Gallium study, that somebody who is more than 70 is, we can limit the number of cycles for these patients. So these are some of the side effects which have been described. Coming to combination of obinutuzumab with CHOP, and the response rate for these combinations are as high as 96% in relapsed refractory follicular lymphoma. So if your patient, and as Dr. Agarwal's MCQ questionnaire suggested, that many of you have started using bendamustine upfront. So if somebody is really progressing very quickly or relapsing, then it could be still a very viable option, because anthracycline-based chemotherapies lymphomas will be anytime better. And we will take some extrapolation from Gallium study, which also showed the improved PFS with obinutuzumab-based regimen when it was used upfront, mainly because the size of the study was so big as compared to some of these studies are much smaller. And then comes, so most of you, because of, I understand in India, because of the, cost of obinutuzumab and the ease of administration, obinutuzumab we use quite frequently because we have approval for CLL and follicular lymphoma. But what is very doable and very effective for the patients is lenalidomide and rituximab. But before I go to this study, I would like to just mention the Gallium study was in the patient who were rituximab resistant. So those patients who have progressed on rituximab, those were the patients who were enrolled on this gadolinium study of bendamustine and obinutuzumab. As compared to that, the len-rituximab study included all the patients. If somebody, those patients were randomized rituximab plus lenalidomide versus rituximab alone, and they went on to receive 4 weekly doses of rituximab, and lenalidomide was given for almost 1 year. And very clearly, you can say that there is a improved PFS, that is 39 months versus 14 months in len plus rituximab arm, and this is only in the relapsed refractory patient, and 2-year OS was 93% versus 87%, again, not statistically significant. If you go into the subgroup analysis, that is important because, as I said, they had taken all the patients, whether the patient received previously rituximab or not. And if you see those patients who are rituximab naive, or if you can see those patients who had received rituximab-based chemotherapy, they did not have very bad hazard ratio. That means it still works in patients who have previously received rituximab-based chemoimmunotherapy. So it's very important that all these subgroups, the response was uniform, and this becomes a very important treatment option for these patients, so particularly POD24 patients who are relapsing very early. And of course, as we have used lenalidomide so much in multiple myeloma, we know how cytopenic patients can become. And when you're combining with rituximab, which can also have cytopenias, it becomes very important to pay attention to what are the grade 3-4 neutropenia, which were definitely higher, 50% versus 13%. And they were more likely to receive GCSF growth factors. But fortunately, the rates of neutropenic fever were not alarmingly high. Higher rates of infection was again expected, and the cutaneous reaction, skin rash, is fairly common with lenalidomide-based chemotherapy. So as far as these patients who are failing early, the treatment option is concerned, if you have obinutuzumab and if patient is not used with bendamustine, then that is one of the equivalent option, or we can go on to use rituximab as a treatment option. And to add to that, if you replace your very effective treatment with even better, that is more potent monoclonal antibody in the form of obinutuzumab. And if you look at the phase 2 study, Gallium study data, 1-year PFS is reaching to the tune of 75% and OS of 81% in this relapsed refractory group. And the grade 3 for neutropenia, again, was not very alarming or was not very high. Definitely, this is a much smaller study, which included 89 patients, and he went on to receive, so many of these patients went on to receive maintenance chemotherapy. It's a very short-term duration right now, which is available, and it's a phase 2. So we always need to take into account what level of evidence. But if your patient was very recently exposed to rituximab, failing very early, then if you have access to len and obinutuzumab both, this could be a very potent combination. As far as maintenance in patients who are relapsing is concerned, there is definitely PFS benefit, and there is concern about giving maintenance because of the risk of infection, risk of specific infection like hepatitis B, and not very proven evidence. But I would leave again to Mausef to give you more details. but I want to just make mention of it here. Then we come on to the targeted agents. So this many of these patients. So one is we identify those patients who are relapsing early. But as you know that the follicular lymphoma is for life, so they will keep relapsing at certain interval. And those patients who are relapsing early, there's a fair chance that they will have again another relapse and then another relapse. So it goes on becoming like you run out of your ammunition one after another, and that's where this kind of targeted drugs could come into picture. Pi3k inhibitors have been, the Fred Hutch, Dr. Gopal was pioneer in bringing these agents to into the follicular lymphoma treatment. Based on phase 2 studies, they got approvals. That was remarkable. So if you see three of them, idelalisib, which is an oral, and duvelisib, which is also oral, and as compared to that, the copancilib is the intravenous. All of them have ORR in the range of 40 to 60%. So it's depending upon if you have access to any of these agents. And the biggest concern is over their toxicity profile and availability. So not everybody has access to them. We have only selective access to these agents through some of the clinical trial. The most pronounced of it is the diarrhea and colitis, which is quite predominant in almost as high as 50% of the patient and can be grade 3 in a very significant number of patients. Pneumonia, transaminitis, and hyperglycemia and hypertension is specific to copancilib. So these are something to be kept in mind. And of course, because as I said, these are now falling out of favor, particularly as the lenalidomide is coming to forefront. These agents are going back to the next line of treatment. But as I said, follicular lymphoma keeps coming back, so you definitely need more agent to bring them into control. What about the graph which I showed about the different B receptor signaling pathways which can be targeted? One of them is definitely proton tyrosine kinase inhibitor, that is ibrutinib. But there was a big expectation, but it failed to show the ORR of only 21%. Again, published by Dr. Ajay Gopal from Fred Hutch. And it seems like, what we rationally feel and believe does not really transpire, but people have not given up on ibrutinib, so they're still getting investigated. All of the follicular lymphoma, they do express BCL, so there was very high excitement and expectation that the venetoclax should work. But again, the ORR is falling short as compared to many other treatments to 38%. The question was again asked whether adding rituximab to this novel agent can improve. Again, it failed to show that it can improve the results as good. So that's as far as the these two agents which are being used very commonly in other hematological malignancy. The drug which has come new is tazemetostat, which is EZ2 inhibitor. And this approval by US FDA is given on this phase 2 multicenter trial of this EZ2 inhibitor, which showed very good overall response of 77% and 65% in case of POD24 group, which is to be something to be definitely noted, and it's approved for somebody who has failed at least 2 lines of treatment. And they must express EZH2 mutation, either Y646, A682, or A692 variant of this mutation. And it can be given orally as 800 milligram twice a day. And the side effect profile also looks quite acceptable and could be a single agent by itself, or it could be exciting when it gets combined with other chemotherapy or a combination treatment. Then I move to another important topic, that is the transplant in this patient. So anybody who is particularly failing early gets the salvage chemotherapy. We do want to achieve as good response as possible. And when they go into CR, then they go for autologous stem cell transplant. And of course, they need to be fit. If they relapse after autologous transplant, or they fail to achieve complete remission, then they could be candidate for allogeneic transplant. But transplant is reserved for young and fit patients, and those progressing within 24 months of initial therapy, and not all the relapse patient, as the other relapse follicular lymphoma, it remains a bit controversial. Whenever the allogeneic transplant is done, nowadays we would prefer either non-ability or reduced intensity. And there is definitely higher toxicity which is associated as compared to autologous, where the TRM is less than around 5%. The TRM of allogeneic transplant can range from 10 to 30%. So it's very important that we select this patient very, very carefully. And this is the transplant algorithm that I can share with you, which was published in Bone Marrow Transplantation Journal. All patients who are relapsing, the question is if they are early relapse or late relapse. If somebody is late relapsing, that is more than 2 years from diagnosis, they generally would not get transplant unless there is some reason, or if they are relapsing very quickly and young patient, that is, then they will be considered. But somebody who is failing or relapsing within 2 years of diagnosis or multiple relapses, they would first go to autologous stem cell transplant if they achieve CR, and of course, they are not considered high risk for MDS or AML or older patient, in which case, or if they have failed autologous stem cell transplant or failed to achieve very good CR, then they are the candidate for allogeneic stem cell transplant. So the first preference for early failure would be autologous stem cell transplant, and that would cure the majority of the patient. But if that is not working, the allogeneic transplant is there. So then the question, which is very important, is the allogeneic stem cell transplant superior to autologous transplant for this early treatment failure? And this is a large retrospective analysis of registry data of CIBMTR by working group, which looked at 440 patients of early treatment failure of follicular lymphoma. And what you can really note that the autologous stem cell transplant, the TRM is the lowest, 5%. Next is the sibling donor and match unrelated donor. And the chance of relapse, of course, is highest with autologous and then lesser with allogeneic transplant as expected. But what is very important that the 5-year PFS or 5-year OS is 70%, which is same between autologous stem cell transplant and matched sibling donor transplant. That means there is no big advantage, or the advantage in terms of less relapse is taken away by the TRM. So the preference is always the autologous stem cell transplant, unless there is some specific reason to select the matched sibling donor transplant. And to some reason, which is not very clear, that the match unrelated donor transplant had definitely inferior survival as compared to the other two groups, and there could be many reasons for that. Coming to CAR-T therapy, it's still an investigational treatment and looks quite promising. But sometimes, we need to, whenever these kind of new treatments are coming out, we need to always look at them carefully, because the studies include a large group of lymphoma patients, and many of them will have chunk of DL, BCL, and all other. To give you a specific example of ZUMA-1, which did include, follicular lymphoma patients and showed overall response rate of 82% and CR of 54% at 1 month. The response tends to drop to 54% at 6 months, and the median duration of 8.7 months, it was 44, and the median PFS of 5.9 months. So at present, it is looking promising, but we probably would look for better data, because it's a very expensive treatment, and there are significant side effects like cytokine release syndrome or neurological event, which your center have to have expertise to deal with it. So at present, CAR-T is very promising, and the way the data is growing, this will probably replace allogeneic transplant in the algorithm. That's what I can answer the question which was put in the chat. And looking at future, it's always very important that we keep one eye on future as to what we will do as our patients are getting better and better drugs. And as you have seen the natural history, the agent first come in relapse refractory. Many of them are now moving to frontline, but that would make the situation difficult when they relapse. And then we need better and newer agents to be available. The most promising of that is Follicular, which is anti-CD79A monoclonal antibody, we did participate in Polaris trial for this agent, and can be combined with anti-CD20 agent, or is getting looked at with many novel agents combination. Another very important drug which is making way is the BiTE antibody, blinatumomab, which is again naturally, if you have an expression, the cancer expressing this antigen, it will get targeted. So is the anti-CD47 macrophage immune checkpoint inhibitors. And mind you, these are the inhibitors which are making big waves in lymphoma currently. So if you have recently attended ASCO or EHA, you know that this is the hot agent which is on the way for lymphoma which is coming. With that, I would like to thank, this is Lake Takapo in South Island in New Zealand. I hope to see you, majority of you, sometime coming to New Zealand. Thank you.
Thank you, Niranjan. We will be there. Don't you host us, we will be there. That was a great talk on relapse refractory follicular lymphoma. Both Raz and Niranjan have done great job in making us understand localized disease and relapse disease. Maintenance therapy is important whenever we talk about non-curable diseases. And to tell us all about that is Dr. Bhausaheb Bhagar. He's professor and consultant medical oncologist, hemato-oncologist, and bone marrow transplant physician at the prestigious Tata Memorial Hospital, Mumbai. Over to Dr. Bhausaheb. We'll have this talk for 20 minutes, and then last half an hour we'll have the question and answer session, and at the 2 o'clock sharp we will close.
Good afternoon, everyone. Thank you, sir, for this invitation. And I thank all the preceding speakers for making background for my talk. The task given to me is maintenance therapy, to do or not to do, and I would be sort of debating for and against myself. We will see some background and rationale initially for the maintenance. We'll see the result with rituximab maintenance after R chemotherapy, various options we saw. We see it after low burden disease treatment with rituximab. We will see it in the asymptomatic high tumor burden and also in the relapse refractory and post-transplant setting. We'll talk briefly about obinutuzumab and lenalidomide R2 maintenance strategies. We'll finally see some downsides of the maintenance and some new data on the response adapted approaches, and then I will sort of conclude the talk. So rationale for this maintenance is that follicular lymphoma remains incurable despite having improved outcome. So though the progression-free survival and overall survival are increasing, the OS more than 15 years as of now, the relapse is inevitable. And what people want is to be living without disease and without treatment. So that is something we want to deliver them, and that's the area where maintenance actually can pitch in and do its job. This is not a new concept. In the olden era, when the chemotherapy was the only available treatment, maintenance treatment was tried, given the relapses, frequent relapses in those times. And what we see in these studies, all these studies used older chemotherapies as for maintenance and interferon. In the later era, they showed a consistent improvement in the progression-free survival. So there is ability to delay the relapse in this patient. But the chemotherapy-based maintenance strategy did not change the natural history of the disease. There was no change in the overall survival. And the downside was toxicity. So there were numerical grade 5 toxicities with that. Interferon generated quite a bit of interest because it was slightly better tolerated than the chemotherapy itself. And a large number of studies were done, and it showed some benefit in terms of overall survival also in the intense chemotherapy and when it was used as a higher dose. So given this background, introduction of CD20 monoclonal antibody really answers the question for a need of a better tolerated maintenance agent. So how this maintenance rituximab or obinutuzumab use is different from induction? First, it acts like any CD20 targeting agent acting on a follicular lymphoma cell and controlling the disease. So this is the same mechanism which will be applicable in the induction setting as well as maintenance setting. But there is slight difference in the maintenance setting. So when the disease burden is low, these maintenance strategies are able to act and control these residual CD20 positive follicular lymphoma cells which are responsible for relapse. So they are able to do that. So this is slightly different way in attack. And interesting mechanism is immune surveillance, where they say there is a vaccine-like effect. Because of these antibody-directed therapies, these patients have dendritic cell recognizing the peptide from this follicular lymphoma cells. So these are slightly different ways in which the CD20 antibody could act in the induction as well as in the maintenance setting, and that might be responsible for some of the differences which we see in this setting. Moving on to the result of the maintenance rituximab in the study, and we'll start with the famous Prima study. So this study was one point whenever we analyze a maintenance study is that we should look at what is the induction regimen used, because there could be an interaction between the induction regimen and the maintenance strategy. Second thing is, did the patient receive the monoclonal antibody in that treatment, or did he receive it earlier? This is the second point to highlight. And third and more important thing to highlight is the tolerance. We feel these are monoclonal antibodies and they are generally safer than the chemotherapy, but they are administered over a long period of time. So keeping an eye on toxicity is also important, and this is how we should address these studies whenever we come across. So coming to first studies, this study is a large study, randomized more than 1,200 patients after receiving rituximab with chemotherapy, and this was CHOP, CVP, and FCM, and not bendamustine rituximab. And responding patients were randomized to maintenance rituximab every 8 weeks for 2 years, that is 12 doses versus observation. And what we can see is the rituximab maintenance lead to significant increase in the progression-free survival. So this is a very good increase in the PFS you can see. This also leads to a decrease in the next line of treatment. So person who is on rituximab maintenance had lesser need of going on to next line of treatment. And next line of treatment that not only included monoclonal antibodies and targeted therapy, but also it decreased the need of chemotherapy. So they are spared of chemotherapy as compared to observation arm. But there was no difference in the overall survival. So this is the crux of this study, where if you use maintenance rituximab, you have benefit in terms of PFS, need to next line of treatment, you can avoid chemotherapy, but your overall survival remains same. When we see the toxicity of this study, so rituximab is fairly well tolerated in this study and most of the studies. So you could see that there is neutropenia. So there is a 4 to 5% risk of neutropenia, a risk of neutropenic infections in these patients, and that we need to be careful. So less than 4 or 5% of the patient would have infection on rituximab maintenance, and we need to be watching these patients carefully since there is no difference in the overall survival. So as to materialize the advantage, we need to be taking care of this toxicity. When this study was updated at 9 years, when it was presented last year, a 9-year follow-up is really stark. So the difference is maintained in between two arms. You can see the PFS is 4.1 in the observation arm, and it is 10.5 years in the rituximab maintenance arm. Means your PFS is increasing 2.5 times. So that's a huge advantage. Time needed to next line of treatment and time needed to chemotherapy is also increased. So this is 6 years and 9.3 years versus not reached in maintenance arm. The overall survival is not different, it is not reached. So these people have excellent outcome when they are given rituximab maintenance in terms of PFS. What this study additionally did was a quality of life analysis. So did this rituximab lead to detriment on the quality of life? So there was no detriment in the quality of life as per the URBC said. So this was well tolerated. Coming every once in a 2 month probably is not really difficult for people, and that can be done on outpatient basis as well. There are additional benefits of rituximab maintenance, and which are highlighted on this slide. So you could increase the CR rates by 20 to 25%. So if someone has finished chemotherapy, he has achieved a PR, by maintenance you are going to get another 20-25% in the CR. It increases time to next line of treatment, and that is some patient really value it. Important thing to note is there was no difference in the overall response rate and CR rate in the next line of treatment. So they responded equally well in the observation as well as rituximab maintenance arm, and that is something which we have to keep in mind when we analyze these maintenance studies. As Agarwal sir had said, that transformation, so there is some benefit of decreasing the transformation in some of the studies, but as all of us know that the outcome of transformation have improved drastically with rituximab. Probably this is a benefit which has not been shown, but it's possibly there given the very small event rate in terms of transformation. This is the subset analysis of Prima, and as you can see, everyone benefited. So irrespective of their age, irrespective of the FLIPI, irrespective of the chemotherapy they received, and irrespective of the response. So there is no subset which didn't benefit or a particular subset which benefited from this study. Moving on to the current more relevant studies where we use bendamustine rituximab and after that maintenance. So maintenance after bendamustine rituximab has been adopted, but there is no randomized controlled trial in this setting, and this is based on the data extrapolation from the non-randomized studies and from the R-CHOP, RCVP or FCPM kind of randomized studies. So this is the analysis of Bright's trial, where follicular lymphoma patient receiving bendamustine rituximab were analyzed when they were given rituximab maintenance as per their treating physician's choice, and roughly 50% of the patient in this study received rituximab maintenance. And as you can see that the BR maintenance led to improvement in the progression-free survival with a hazard ratio of 0.5. That means there is roughly half decrease in the risk of relapse when patients were given rituximab maintenance after bendamustine rituximab. There was improvement in the R-CHOP, CVP with maintenance arm as well. But important thing is this study showed a trend towards overall survival in patients receiving rituximab maintenance after bendamustine rituximab. The hazard ratio for overall survival in the R-CHOP, CVP arm was slightly. I think as highlighted by Sir, it is important to look the toxicities of bendamustine rituximab, and this becomes really important when you use maintenance therapy for long. And another thing is if you use more potent monoclonal antibody, for example, Gazawa or obinutuzumab. As you can see in this study, there is a numerical difference between the grade 5 adverse events. So, for example, if you see the deaths in the bendamustine and rituximab arm, they are slightly different when they are compared to R-CHOP or obinutuzumab CHOP trial. So we need to be mindful of this association of upfront chemotherapy with bendamustine and increase toxicity when you are using maintenance chemotherapy after bendamustine based induction regimen. And the reason they have highlighted is this is from the Gallium study. When bendamustine was given, the total CD3 count has fallen in patients receiving bendamustine. So this regimen not only depletes your B cells because of the CD20 antibodies, because of the bendamustine, the T cells fall, and these T cells recover after some time. But this phenomena is not seen after CHOP or CVP, and that might be a reason for this patient having non-neutropenic opportunistic infection. So there were reports of viral infections, PCP, atypical infection in bendamustine arm, and this is something we have to keep in mind. Moving on to the role of rituximab maintenance when someone is treated in a relapsed refractory setting. So I'm for sake of time, I'm covering only one study per indications, and this is one study. This is URTC study where rituximab maintenance was used after R-chemo in relapsed refractory setting. It is important to note that these people had not received rituximab in the first line setting. And similar to the Prima study, what you can see is there is improvement in progression-free survival. There is improvement in the time to next treatment. There is also improvement to time to next chemotherapy also. And surprisingly, this trial also showed some improvement in the overall survival. So this is in contrast to what we saw in the rituximab maintenance study in the current era. These studies were planned and done in early 2000s, where rituximab was not commonly used in induction. So this is one thing we have to keep in mind. Another study which looked at rituximab maintenance in the relapsed refractory patient post autologous transplant. So this is an interesting situation where you are treating patient with a very high doses of chemotherapy. For example, beam was used in this EBMT analysis, and what you could expect after this. I brought this study for younger colleagues and students in the audience because this study has an interesting design. This study did two things. They tried purging with rituximab prior to PBSC collection. So this is a cumbersome thing. Probably people will not be doing it right now. But just to highlight that certain things can be important. So these are two randomizations. One is the rituximab purging before PBSC collection versus no purging. And the second randomization is after transplant rituximab maintenance versus no maintenance. And what you can see is there is a benefit of rituximab purging in this patient in terms of progression-free survival, but no difference in the overall survival. And similarly, there was a benefit of maintenance for the post-transplant patients, but there was no change in the overall survival. So this again highlights that even after a very strong chemotherapy like a conditioning beam, you could achieve something by just giving rituximab maintenance over prolonged period, highlighting that probably there is a different way in which rituximab maintenance acts after the induction or maybe a salvage chemotherapy and transplant. This study simply shows that if you cannot do purging, which is difficult technically nowadays, or people will not be doing that, rituximab maintenance can be done. And this highlights that either purging or maintenance should be done in such patient population. This is going to be a rare scenario today, but that's what data we have. Next, we move on to the rituximab maintenance in low tumor burden disease. So if for some reason you want to treat a low tumor burden disease and you don't want to radiate these patients, what you can do is you can give them just rituximab induction, where patients are given weekly rituximab. That's just induction. And the maintenance is after this induction, you give rituximab maintenance for a prolonged period of time, like what we did, what we saw in the upfront setting. And this is an interesting way to look at it. So you have decided these people to be treated when they are really asymptomatic, and probably the treatment goal here is possibly keeping them in the remission for a prolonged period of time. So these are the responses in this study, and you could look at the 25-month responses, that is the end of the maintenance study. You can see that if you give rituximab maintenance, your responses are 75% plus. You have 70% CR rates. But if you just use it in induction, they are 33% CR rates and response rate is 57%. So using just rituximab maintenance probably leads to lesser responses. The depth is not also really good. And importantly, these are obviously going to last lesser. So if you for some reason decided to treat a low tumor burden patient with rituximab induction, then probably it is important to consider a prolonged schedule. This study showed that if you this study, the rituximab induction arm was not really popular and there was slow recruitment. So the arm was stopped after some recruitment. So wait and watch versus maintenance showed a significant difference in terms of time to next line of treatment, progression-free survival, but as expected, there was no difference in the overall survival and no difference in the histological transformation in this very good prognosis disease. So you see these curves, most of them are more than 85-90% of the times. When this study looked at this rituximab induction versus maintenance, there was no difference in the time to next treatment. So most of them required treatment at the same time, but there was a bit of progression-free survival advantage when you use rituximab maintenance, which is quite as we would have expected by now. So given these data, various settings, various inductions, and various maintenance strategy, this is a meta-analysis which kind of summarizes everything. So this has included 7 studies which have analyzed treatment naive patient as well as relapse and refractory patients. And this is individual patient data meta-analysis, so quite a bit of value carried with it. And what you can see is there is an overall survival advantage as per this meta-analysis when large number of patients, more than 2,500 collected, and this advantage was not only in the first induction but also in the person who is receiving a relapse setting. So this meta-analysis and few randomized studies also have showed some overall survival advantage in some of the relapse settings, but the overall survival advantage in the upfront setting is limited as of now. This is highlighted by this chart where it didn't show any significant advantage for overall survival in the first line setting, but there was advantage in the relapse and refractory setting. And this is mainly because of the weight carried by the Prima study where there was no overall survival advantage. I will briefly speak about obinutuzumab and len maintenance in this context, and as we saw that obinutuzumab led to progression-free survival advantage as Agarwal study has shown. This study was not comparing obinutuzumab maintenance versus no maintenance. It was comparing obinutuzumab versus rituximab as a part of induction and maintenance. So it is difficult to dissect the value of maintenance obinutuzumab per se, but I don't think we are going to use a split maintenance or a switch maintenance kind of thing. As shown by sir, there is a PFS advantage, but what I wanted to see you is the obinutuzumab and rituximab group. The post-induction CR rates were pretty similar. So pointing toward the fact that probably the whatever difference in the PFS was because of the post-induction treatment and because of the obinutuzumab used for prolonged period of time. So there is a beautiful editorial by Dr. James Warmitas on this, and he says the race is still out for obinutuzumab versus rituximab used in the follicular lymphoma, and it's an interesting read. And as Sir has highlighted, it came with a toxicity concern, and this was really a potent monoclonal antibody, so obinutuzumab, and when you use it particularly with the bendamustine, the toxicity is really important to watch. So these toxicities are in the double digit. If you see the bendamustine infections are 16%, CHOP is 3.5 or less than 5%, so and CBP is less than 10%. So this is an important point for all of us to remember as the bendamustine usage is increasing and it has become popular for tolerance and safety issues. Coming to relapse setting and role of obinutuzumab, probably this is the way this antibody would be used in our setting at least. So for relapse patient who are rituximab refractory or who had a relapse and rituximab sensitive. And Niranjan highlighted this study enrolled patients who were rituximab refractory. So they relapsed within 6 months of the treatment. And that is how they were eligible for receiving bendamustine versus bendamustine and obinutuzumab. So what this study again shows is there is a benefit of obinutuzumab added both in the induction as well as the maintenance. And similar to the story with the gallium, the response rate in both the bendamustine and bendamustine obinutuzumab were same, but the curves separate afterwards. So it points toward the fact that probably maintenance led to some separation in the curves over a period of time, though this didn't translate into overall survival advantage. So this is kind of same story repeating with every study as we see along. Important point is obinutuzumab toxicity, and this again is highlights. I will just want you to see this figure of 29% grade 3 to grade 5 adverse effect when obinutuzumab bendamustine was used for maintenance in the relapse refractory setting. So this is not something which we can forget. We must be careful in handling this regimen if we use in our patient. Coming to rituximab lenalidomide story, so this is as sir has discussed this trial very extensively. But one thing I remember people saying about is this is the most positive of all the negative studies which has been done in follicular lymphoma. And this COVID era lenalidomide has probably all of us are used for patient who doesn't want to come or we don't want them to come to hospital. There was no randomization question in this study, but if you use lenalidomide rituximab as an induction, as a maintenance, and if you use chemotherapy as induction and rituximab as a maintenance, then what happens? This interaction, it is important to check whether it's like a bendamustine story or it's easily tolerable. And there is no PFS difference. So this study was negative because it was a superiority trial. There is no difference in the overall survival, but that's not expected also. But in terms of toxicity, as Sir said, neutropenia was more common with the rituximab chemotherapy arm, while diarrhea and other side effects were common. So rituximab and lenalidomide prolonged therapy. The rituximab maintenance did not lead to increase in the adverse effect or side effect of lenalidomide, and that's how probably the regimen can be used if someone is opting for a chemotherapy regimen. Moving on to downsides of this approach. So what are the downsides? First is neutropenia. So rituximab is known for delayed neutropenia. We saw grade 3, grade 4 side effect and some grade 5 event with strong chemotherapies or obinutuzumab. Hypogammaglobulinate occurs. It is usually not treated itself, but that predisposes people to infections. And rare cases of fatal PML have been reported that we should be aware of. The most important criticism of this approach is not being able to improve the overall survival. Okay, but as you would have realized by now, most of the studies in follicular lymphoma, be it BRIGHT study, be it STILL trial, most of them it is difficult to show overall survival advantage because of the long natural history of the disease. And the PFS, if it is acceptable to patient, can be used as a valid endpoint. Other criticisms are the timing and duration of maintenance rituximab are empirical. They are arbitrarily decided. So, for example, 2 versus 3 monthly rituximab, there is no toxicity difference in. There is no difference in the PFS, and some studies are compared short-term maintenance 8 months versus 2 years. Some studies shows 2 versus 4 years. So this is a variable. What we know as of now is if you use it more than 2 years, there is increased toxicity 2 versus 4 years. So probably it is best to limit your maintenance to 2 years duration if you at all use it. Next thing is when you look at this maintenance question, it is important to analyze what are this patient dying of. So cause of death in follicular lymphoma in this European and American joint analysis. So what you can see is on the left side, less than roughly 10% of the patient were lost because of the lymphoma. But 3 to 5% of the patient have other cause mortality, like treatment-related death, other malignancy, and other cause. This is slightly magnified in this, and these 3 things cannot be ignored. But if you see this as per the age, as the age advances, so this is for people less than 60 years, this is 60 to 70, and more than 70. The treatment-related toxicity and other causes start creeping up. So the competitive events are going to be more, and we have to be careful in this situation. So this will help us to choose the the regimen which is going to give us more PFS but is going to be slightly toxic. Second thing we see as per the baseline risk. So as the FLIPI score increases, in FLIPI 0, less than 5% of people have problem because of the disease. But if you have FLIPI 3, the competing event, nearly 30% people would have follicular lymphoma related death. So in such situation, probably preventing a relapse or preventing progression would be important, and there you could take some toxicity risk in an appropriate patient. So can we adopt our therapy maintenance in based on some of the ideas? And the rationale for this is roughly 30 to 40% of the people are not going to require any second line treatment. So if you are going to give them any treatment, that's going to be not needed for these people. Next is patient who respond well, they do very well. So patient who have achieved CMR on the PET scan, their outcome is more than 90-95%. So as per this, can we choose patient based on their response to induction therapy? And there are some studies. So one study which is not probably response adapted, but that answers questions whether we should give them maintenance to everyone or you treat when there is a progression. So in this resort study, patients were given rituximab inductions, and after this, they were randomized to rituximab maintenance versus rituximab every 4 weekly at every progression. So if there is progression, you treat 4 doses, then you stop. If there is progression, you again treat. So this is kind of a go slow approach. And what this study showed that there was no difference in the treatment from free survivals. All of them did very well. But cytotoxic treatment free survival was better in the rituximab maintenance arm. So allowing them to progress and then treating probably led to more progression in the patients who were not given maintenance treatment. And there was more use of rituximab in the rituximab maintenance treatment. This is one study which has been reported in the abstract form as of now, and this is follow 12 trial where a patient with PR or CR after treatment were given standard maintenance, and if they were in the PET adapted arm, they were treated with rituximab versus observation. So this study, in fact, showed that the approach of giving maintenance to everyone leads to better event-free survival. So this PET-adapted approach, PET and MRD negative patient when not given maintenance had higher chances of relapse. So this is one study which has come out. The next study which is ongoing is a Petra study, which is randomizing patient PET negative patient to rituximab maintenance versus no observation, and PET positive again to rituximab maintenance observation. Is slightly cleaner design, so probably we would see some result from that. Next is the advantage in terms of subcutaneous rituximab not available to us, but if it becomes available, this is going to be very important for a patient like plan for maintenance chemotherapy. This has been shown in Sabrina trial that though there is delay in the catching up the level of the first cycle, where they recommend to give IVs to start with IV, after maintenance, the pharmacokinetic is similar to that of intravenous. So this will be very useful if it becomes available to our patients in India. This was equivalent in terms of efficacy. The PFS is same in this Sabrina trial, and there were no toxicities. Subcutaneous reactions were there, but these were grade 1, grade 2, and manageable. So lastly, I will put two cases for you to just think over. So case 1 is a 54 male. He is a real life patient. He is a foreign national. He came with generalized lymphadenopathy and bulky inguinal lymph node. We had to do his inguinal lymph node biopsy to rule out transformation, but that was not conclusive. Given this suspicion and his young age, we treated him with R-CHOP with good tolerance and his CMR post 6 cycles. And now the question is whether we'll give him rituximab maintenance or not. And this is one case. I contrast this with the second case. This is 74 female. She is traveling from West Bengal. She is diabetic and obstructive airway disease. She had follicular lymphoma, again advanced stage. She had a high tumor burden disease. She was treated with BR 6 cycles. She required dose reduction in the 4th and 5th cycles, and she is now CMR. So these two patients present different patients. The first patient represent excellent candidate, probably in my opinion, for rituximab maintenance. In fact, we treated him with maintenance rituximab treatment. He finished it 1 year back, but he had a tough time when he recently developed a COVID infection. Then this lady was not given maintenance rituximab. She is doing fine, and she is being managed with teleconsult in this COVID era. So this is my conclusion. Rituximab maintenance prolong the PFS, and there is conflicting data on overall survival. There is small but important increase in the serious toxicity, and we need to be taking this into consideration when making the decision in the individual patients. There is risk of toxicity different across different subgroups, and it varies with the type of induction therapy one is using. So probably we have to do individualized decision. So the final answer to this question, I would say that it can be done in select patients, and I thank you for this.
Thank you, Bhausai. That was great. So we have now some amount of time left for the questions to be answered. I'll read out the questions. The first question is from Dr. Shyam Rathi, 30 years old female, unmarried, stage 1A follicular lymphoma, grade 3A, has a mediastinal lymph node of 5 centimeters. So, Dr. Rayas, this is for you. What will you do for this lady? Stage 1 mediastinal 5 centimeter mass, 30-year-old young woman, and histological grade is 3A.
Sir, in our practice, we will be treating this young lady. I will offer her the chemotherapy-based regimen, Rituximab plus chemotherapy-based regimen. I expect not going for because of the mediastinal mass. I will not be choosing for radiation. I will go for radiation, Rituximab plus chemotherapy-based regimen, followed by maintenance.
Chemo radio followed by maintenance.
It could be some variations, sir, because in like locally here, similarly I used to think that I would try to avoid mediastinal. But what we do here is we definitely do a PET to make sure that we are not missing out anything. And if there is no family history of breast cancer, we still go and give radiation. Because as you know, follicular lymphoma is so sensitive to low dose radiation, and that can completely cure the patient. So,
Niranjan, can I give just 400 rats? How low?
Yes, it can be. It can be, but we would, if you're treating it as the only treatment, then we would give it much higher.
What, 2,000?
That's the difference when I came here. That's the first thing I noticed, in the similar case scenario. I had one patient, and when we present every case to lymphoma multidisciplinary meeting, and then this was the verdict which came out, which surprised me too.
Right. The next question is, any data on R-square therapy in early stages, newly diagnosed follicular lymphoma? So for systemic disease, I have presented. Rayas, would you like to say, is there any data for the localized disease?
Sir, I couldn't get you this question. Can you?
Localized stage 1-2 follicular lymphoma, is there data on R-square, that is Len plus rituximab therapy?
Okay. So the relevance is basically advanced. It's for advanced. So localized, I don't know, sir. I am not updated whether the RL we have for the localized one. It's basically the advanced untreated one.
Right. Again, to the best of my knowledge, there is no data for the localized disease. The next question is, can PET scan allow to skip bone marrow examination in follicular lymphoma? So, first of all, it's absolutely not a mandatory thing to know whether the bone marrow is involved or not. FLIPI2 includes bone marrow for its staging, but then most of the people don't do, and therefore FLIPI2 has been criticized that you cannot apply it very easily. Beta-2 microglobulin bone marrow is the missing data for most of the patient. PET is definitely not trustworthy as far as the bone marrow is concerned, as we just discussed in my presentation. Only thing is that it has not made a major impact in changing the line of treatment, whether by biopsy you showed that those 40% of patients that a marrow is involved versus not involved. Other faculty, would they like to differ in any way?
It would be applicable for early stage disease, sir, which you treat with radiation.
For early stage disease, yes. How often will you find that the PET is showing stage 1, 2 and marrow is involved?
Very rarely. So if PET is negative and there is no cytopenias, we don't do the bone marrows.
Then bone marrow is
unless there is some suspicion.
Very. The next question is, updated data on R-square shows higher MRD and PFS compared to R chemo. So can we see R2 as the new standard of care for advanced stage follicular lymphoma upfront? So my answer to this will be no. This is not the standard of care upfront at the moment, basically because of two reasons. One, short follow-up, as against like Prima studies and all, we have very long follow-ups available. And second, length to be used for such long period, one is not at the moment very comfortable. So waiting for the data where len was used for a short period and waiting for the data where len obinutuzumab has been used. So it's a treatment option for people who are not keen to take chemo, but it is not the standard of care at the moment. Anybody wants to differ?
No, sir.
Okay. Next question is, why is the dose of len in R square 20 mg and not 10, 15 or 25 mg? So there has been phase 2 data in which there was a little bit of study done, and len dose is in two parts in R square. In the beginning, it is 20 mg, and those who get into CR, it is reduced to 10 mg. Those who don't get into CR, 20 mg is continued. Others?
Yeah, depending upon the clinical trial framework, as the trial phase progresses and they find out the drug doses and then what was the study design, depending upon this kind of sometimes variation fall in, just for the information of the delegates.
Right. We have a whole webinar coming up on len next Sunday, only len being discussed. The doses are so different in follicular lymphoma versus multiple myeloma versus other diseases. It is getting into disrepute in chronic lymphocytic leukemia. All that is going to be discussed. So log in next Sunday. The next question is complete molecular remission, that is BCL2 negativity, a goal in the treatment of follicular lymphoma? So we had put up this question to the international forum just about a month back, and they said at the moment in clinical practice, no. So unlike CLL, where it is getting into the clinical practice in follicular lymphoma, at the moment it is not there because US FDA has not approved it. European agency has also not approved it, but in future it could be. Other faculty? Will you like to look at the BCL2 negativity?
No, sir. I agree with you. No.
Okay. The next question is, achievement of complete metabolic response has a significant effect on PFS with 3-year PFS of 84% and 55% for patients where MRD was detectable. Okay, so that's the comment, why MRD may have to be, should be done. So that's something for future, yes. Which one has got a higher incidence of second malignancy? Len-based therapy or bendamustine-based therapy? I have no information on this. Anybody? Because Len-based therapy is a short follow-up data available. To the best of my knowledge, just a couple of years data available. But anybody wants to say anything?
No, one is len-based, and second is those patients who are going for transplant. And as we are aware, the autologous stem cell transplant can produce myelodysplasias in the future. That's one concern. And whether they combine with lenalidomide, whether that will translate. So currently there is no data to suggest that. But that...
Right. Next question is for Niranjan. If someone didn't respond to BR, he was switched to R-CHOP, he responded. Will you like to do an upfront autologous for this patient?
This is the first presentation where it was a refractory and then responded
to R-CHOP. Refractory to BR and then responded to R-CHOP.
That typically is a kind of, we would say, refractory patient, so is likely to do not so well. So this will definitely be a candidate if it's suitable for that. That would be the preference. If patient is fit and then we would prefer autologous stem cell.
So you will advise that, okay?
Autologous, because
next question is for autologous. Next question is for Bhausai. do you monitor IgG level on Rituximab maintenance?
No, sir. For the simple reason, we don't do anything with that. We don't replace this. We don't monitor. But we keep on seeing people having low globulin values. I think it's important to keep eye on their globulin and look for infections actively in these patients.
And continuation of that is that if the IgG level was done, if it was below 400, will you stop Rituximab?
Yes, so I think our threshold to stop rituximab should be based a priori risk of relapse. So maybe you could take FLIPI or maybe you could take any other risk stratification we use. And second is the risk of infection person handling. So if his globulin is going down and if he's a frail person, probably it's important to look for toxicity. So he being a low risk person, I would stop. And if I think I can manage toxicities, probably with a rigorous prophylaxis in a high FLIPI or a high risk patient.
Thanks, Professor. Again to you. If the IgG level is below 400 and patient is getting recurrent infection, will you keep this patient on replacement therapy with intravenous gamma globulin? Will you give pented prophylaxis or will you do both?
So first thing is I will stop the rituximab maintenance, and that's important to do. Second thing is immunoglobulin replacement it is difficult to show the benefit, but in a patient who is getting recurrent infection, probably I will do it. This patient, I will typically be putting these patients on Septran prophylaxis or cyclovir prophylaxis. Pented, I'm not very sure how much it will help in this patient, but I would be doing their prophylaxis, Septran, PCP, and immunization.
The next question is, in the COVID-19 pandemic, will you avoid use of BR therapy?
Yes, we did. So when the pandemic this was on, the lymphoma working group here had decided that we should defer bendamustine-based chemotherapies. We have resumed now.
Now you are in a very, very different situation than the rest of the world. Okay, fine. Another question is, if persistent low tumor burden is left at the end of 2 years of rituximab maintenance therapy, can you continue the same? To Bhavsek?
I think this is difficult when there is no data, but only thing I can tell you is in that study where 2 year versus 4 year maintenance was done, there were more toxicities in the 4 year arm. Then the SWOG US study where they had R-CHOP, radioimmunotherapy, and maintenance till 5 years, the toxicities were significant. There were 40% people who stopped the maintenance. So I think I would stop the treatment for toxicity concern and observe that patient.
One question is about the difference in the infection after BR and after R-CHOP. I think in the view of shortage of time, we have discussed this, so we're going to skip this. Role of ofatumumab in maintenance. The drug has been withdrawn from not only Indian market, large number of countries, so we'll skip that as well. A patient with relapsed follicular lymphoma and a relapsed follicular lymphoma with transformation. What is the basic difference in the management, Niranjan?
So yeah, I saw the question, which was quite interesting. So if somebody is showing progression, Richard's transformation or transformation to DLBCL, it is very important that they receive anthracycline-based chemotherapy, which could be CHOP or DA-POC that we use here, along with monoclonal antibodies. And we do have a preference that we send them for the autologous stem cell transplant. But in ideal circumstances, if somebody gets into CR, we can still wait if patient presents with a transformation at baseline, that is first presentation, versus somebody who is relapsing, then we are very categoric that if somebody is relapsing within 24 months, then they go for salvage chemotherapy followed by transplant. That's clear, versus transformation.
Thanks, Niranjan. The next question is role of radiotherapy in a treatment-naive patient who has got systemic follicular lymphoma. So I'll take that. We usually do not give radiotherapy to a patient who's got a systemic follicular lymphoma. And if there is a residual disease, then it's a high-risk patient as such. We follow exactly what Niranjan has mentioned. A 49-year-old male, stage 4 follicular lymphoma, ECOG1, receives 6 cycles of BR, has then needed 6 cycles of R-CHOP and remained disease-free for a while and then relapses. So, okay, in short, got BR, got R-CHOP, then he relapses. As he is only 49 and has got a bad disease, can we go straight for allogenic transplant, Niranjan?
So 49 years old and patient is exposed to bendamustine. So if you remember in my algorithm for deciding for transplant, one of them is if you cannot harvest, and second is if patient is younger and you have a good donor option available, the sibling donor particularly, then this can be definitely a discussion, but they can still do quite well with autologous.
Okay. And he also wants to know the conditioning regimen for allogenicity.
So allogenic stem cell transplant for follicular lymphoma, what is quite clear about is the myeloablative regimens are not preferred. So we generally like to go with non-myeloablative or RIC. And in that case, you can use quite a different variation depending upon what your institutional preference. But generally, if you have a TBI-based regimen, that should be the ideal one.
Okay. If CD25 is positive on follicular lymphoma, is it a more aggressive disease? Is the next question. Anybody can take it up.
Yes, I have not come across CD25 particularly as a marker, so probably pathologist
as well. Others have an answer? Okay. Does bendamustine affect stem cell harvest? Is the next question.
Yes, certainly affects, and that's going to be the one.
Okay. There's a newly diagnosed case of follicular lymphoma, and biopsy at a second site shows histological transformation. What will be your starting protocol?
In fact, that's one of the salvation.
Okay. Do you look at MRD before doing autologous transplant, Niranjan?
So if we get an access to doing a PET scan, that would be very ideal, but it's not routine. We don't do it. But there are studies, particularly more of a DLBCL, where if you document that there is a PET negativity CMR, it translates into better outcome, but not very specific for follicular.
Next question is, the patient cannot afford PET scan, whether CT scan will be adequate? The answer is yes. Can't afford, you move on. Initially, stage 3A disease treated with BR followed by R maintenance now has an asymptomatic single site nodal recurrence. Will you wait and watch or start treatment? Dr. Rayaz and Dr. Bhausab?
Wait and watch, sir.
Wait and watch.
I agree.
After autologous transplant, there is a quick relapse. Treatment, Niranjan?
If the patient relapses after autologous, then generally they would go for some form of targeted or salvage treatment followed by allogenic transplant or CAR T if you have access to CAR T trials.
Fair enough. After BR therapy, EOT PET shows residual disease. How will you follow up this patient? So refractory disease, Niranjan?
So it depends upon if patient has, because it's a kind of indolent disease, if patient has shown sizable response, we do prefer to keep these patients under observation for some patients. But this is a bad marker that they could progress very quickly. So our monitoring will be quite intense. And if there is very sizable amount, of course, then it will be considered as a refractory disease and receive salvage followed by possibly transplant.
Next question is whether PET SUV value can distinguish between follicular versus transformed lymphoma. The answer is no. SUV values are taken to decide which site to do the biopsy. SUV value itself cannot tell you that this is a transformed lymphoma. Role of maintenance in early follicular lymphoma when a patient was treated only with rituximab monotherapy. Dr. Bhausai?
Yeah, so with only induction monotherapy, the 4 weekly 4 doses, the responses were low and they lasted less than 2 years. So if you really want to have a meaningful thing, then the protocol of having 2 weekly doses would give you better responses and better PFS. And the toxicity was really not a problem. So I would suggest if you are decided to treat, probably a prolonged duration would be better.
The next question is that we mentioned about chemoimmunotherapy 6 to 8 cycles. So 6 or 8. So, ma'am, 6 cycles are for the RCHOP and BR, 8 cycles are for RCVP. So it's not that you give 8 of RCHOP and BR. If a patient has hypersensitivity reaction to rituximab, what is his chance of tolerating obinutuzumab? I don't have an answer to this. Anybody there?
This time it will be very unusual that we can't give rituximab altogether, but technically they are.
Right. So first dose of rituximab can be bad. That doesn't mean anything because from second dose onwards there may be nothing at all. So should not get
antibodies. So we can.
That's right. Yes. I think we have come to an end of most of the unanswered questions. There are many others, but they have been covered during the talk, so I'll have to skip it because of the shortage of time. I will just like to read out the name of people who have been putting up these questions. Dr. Shyam Rathi, Dr. Bharat, Dr. Abhinil Mittal, Dr. Shweta, Dr. Dipti Rani Samanta, Dr. Steffi Chako, Dr. Haritha, Dr. Ulfat Ara Wani, Dr. Hamza Dalal, Dr. Akshay Lahoti, Dr. Pankaj Shah, Dr. Satarupa Mahopatra, Dr. Ketan Modak, Dr. Dilip Harindran, Dr. Some are repeat questioners, so I'm not reading their name, and Dr. Pradeep Shri Vardena. We are thankful to you for making this question and session so interesting. I'm grateful from my part to everybody involved in the genesis of this webinar, including the faculty, the discussants, the participants, etc. And I hand over now the stage to Mr. Manoj from Intas, who has been our financial backbone for doing all academic activity. Over to Manoj.
Sir, I attend sessions organized by you as a student, not as a financer or a sponsor, because it's a feast, and I think I have earned my lunch, and so have so many attendees. Sir, there were 305 of them across the country. 273 from India, 32 doctors from UK, Kenya, Nepal, Bangladesh, Myanmar, Sri Lanka, Malaysia. Thank you to all the experts, teacher of teachers, Professor Dr. M.B. Agarwal, Dr. Niranjan Rathod, who was looking lovely from Dr. Riyaz Ahmad, from Rajiv Gandhi, Dr. Bhavsa Bhagat. Thank you all very much to make it so very interesting. And I think we have earned our lunch today. Thank you so very much.
Thanks. Have a wonderful lunch. Thank you.
And thank you.
Thank you so much, sir.
And to my team. Thank you very much.